Good afternoon, ladies and gentlemen. I hope we are doing well, and allow me to welcome you to today's session that is hosted by the Ministry of Health, Emergency Medical Services, and CID Global Health. And today we are going to be discussing yet a very important topic, which is around IPC in this setting of the Ebola outbreak. And as we start, allow me to introduce the people who are going to be leading us in this afternoon. I am Ignatius Asasira. I am a resident of emergency medicine at Makerere University. And our first speaker, who is going to discuss the principles of IPC for the Ebola response, is none other than Dr. Sauda Kizito Namubiru, who is a clinical microbiologist and an IPC specialist with the Ministry of Health. And after that, we shall have a physical demonstration of donning and doffing and of the appropriate PPE in response to an outbreak like this. And it will be led by Ms. Chomhendo Judith Jolly, who is an assistant nursing officer with the Mulago National Referral Hospital and an IPC trainer. She will do it along with Dr. Charles Ntambi, who is an IPC specialist supporting the Clinical Services Department at the Ministry of Health. And we shall continuously have the active chat. Please, let's make use of the chat. It's exactly 5 minutes past 2. And at this moment, allow me to call for your expectations of today's conversation. I'll take two well-wishers. Feel free to unmute and tell us your expectations. The rest of us, we can have our expectations typed in the chat. We have a very active chat, which we're going to monitor closely at the end. So any two well-wishers on the chat that could unmute and tell us your expectations. I see we already have 98 members, so feel free to unmute, members. Tell us what you... Okay, please, you can raise your hand. I'm told you don't have a host rate. Raise your hand and we unmute you. I'm not seeing anyone yet. What about in the chat? Do we have expectations in the chat? Okay, someone is... Rachel Ampere has said hand washing. I'm assuming that's one of the things she wants to learn. Okay, what about the rest of us? Okay, let me, in no particular order, let me request Mr. Tom Chove.
Thank you so much, Chair, and all the panelists of today's discussion. My concern or my question or expectation would be the different levels of IPC application in regard to pre-hospital environment. Does the driver has to put on the same PPE with the caregiver, something like that? Thank you.
Okay, that has been well noted. And someone else in the chat has said at the end of the session, we expect a certificate of participation. Okay, that has also been well noted. Then waste segregation, donning and doffing physically, and I'm telling you, your expectations are going to be met. So let's continue typing our expectations in the chat. At this moment, allow me to welcome our first speaker. Once again, she is Dr. Sauda Namubiru Kizito, who is a clinical microbiologist and a specialist as far as antimicrobial resistant services are concerned. Allow me to welcome her and let's all listen in. Please keep the questions in the chat coming, and in case we miss it, we shall really get back to you. Over to you, Dr. Namubiru.
Thank you so much, Dr. Ignatius, for that wonderful introduction. And once again, thank you, CID Global, for this opportunity to have our frontline healthcare workers, managers, the support staff have this orientation on infection prevention and control, largely within the setting of an Ebola outbreak, but also it should cover situations where we don't even have an active outbreak. Continue. So we shall look at the introduction, the components, how are infections spread, what are the standard precautions, transmission-based precautions, the hierarchy, and risk assessment. So as a way of introduction, we are wondering what is infection prevention and control. It is none other than a scientific approach, but this approach has practical solutions to prevent harm caused by infections. And it is grounded in principles of infectious diseases, epidemiology, social science, and health systems strengthening, but is also rooted in patient safety and health service quality. So basically, it is about protecting the patient, but also the healthcare worker. So, like I said, IPC is a very selfish phenomena because we know that once you get infected, and I'm not saying it is not because people care, but when you get infected and you die, we shall mourn you, but we shall forget you, and your children will probably be the only ones who remember. So we are saying the phenomena looks at, first of all, protect yourself. Then when you finish protecting yourself, protect the patients that you're working on. And then when you finish protecting the patients, then protect the family and the community. And in this case, I mean the community around the healthcare facility, the community to include the service providers. They could be maybe engineers, distributors, but also the general community outside. And we are targeting all healthcare workers, the managers, the clinicians, the IPC practitioners, but we also have those ones who are dealing with primary care clinics, emergency departments, infectious diseases, and more. So this encompasses what one of our colleagues said, the caretakers, the drivers, the janitors, or the cleaners. So in terms of core components, IPC has core components, which start with the IPC program, but then it also takes consideration that we must have an enabling environment. Sometimes it's very hard to practice IPC if you do not have an enabling environment, and that is why we are saying the accountant in the hospital, the administrator is as important as the clinician who is doing the actual IPC. And we have multimodal strategies. And in so doing, we look at a stepwise approach towards the implementation of the standards at national and facility level to provide minimum protection and safety to patients, the healthcare workers, and the visitors. And it is based on the WHO core components for infection prevention and control program that we all should be having in our facilities. Next slide. So the question is, how are these infections spread so that we go ahead and prevent them? And how the infections are spread depends on the particular infection. And the infections are spread in a scientifically explainable manner, and this is not something that is magic. It is not something that we are inventing, but it's something that is scientifically proven. So in order for an infection to spread, we must have a chain that is interconnected. And when you break one of these chains, then you stop the transmission of the disease. So we have a pathogen. Now pathogen, forget the word pathogen and just put a germ. You can put Ebola in this case, you can put COVID-19, you can put HIV. When we are in peace times, this pathogen Ebola is somewhere. For example, since it is Ebola we are talking about, it is in the bats, it is in those wild animals, and that is the reservoir. So how that animal, that pathogen leaves that animal to go into a human being is what we call the exit point. So it could be through butchering, could be through maybe slaughtering and you're going to eat it. And the transmission pattern now occurs. And when this transmission pattern occurs, even you as the patient, potentially, you must have an entry point, because if somebody butchers it and you look at it, it will not just fly to you. So it can go through your mucous membranes, for example, through your blood, and then it finds a susceptible host. Now, for some pathogens or germs, they will only go into people who are susceptible. For example, if it is TB, you will find that it is only a few people whose immunity is compromised who will get the TB. But then for pathogens like Ebola, everyone is susceptible. So, and that is how you get the vicious cycle. So as a matter of principle, if you want to stop the chain of transmission, then you must break the chain at whatever point. Either the pathogen remains in the reservoir, or it does not get out from the reservoir, or the transmission pattern is destroyed. And this transmission pattern could be contact, it could be airborne, it could be droplet, it could be fecal oral like cholera, and then the entry point. So that is why you're not going to just get HIV by looking at a beautiful woman who has HIV. There must be an entry point, which is the genital organs, and that is how it enters, and then you must have a susceptible host. Next. Yes, so like I said, we have the infectious agent. This is just to further explain the chain. So you see that the infectious agents could be bacteria, fungi, parasites, prions, viruses, name it. And then we have the reservoirs, who could be people, animals, or water, or food. Then the port of exit, then the transmission, it could be droplet, contact. And with the transmission, it really determines a lot of our IPC. Because somebody might be asking, why are we not using a lot of, for example, masks when we have Ebola, yet for COVID, we're using masks? Because we know that for Ebola, the contact is, the mode of transmission is contact. But then when it is COVID, it is airborne or droplets. So we want to prevent. So this is very key, and it determines how you prevent. Then, of course, we have the port of entry, and these are the ones that we protect. I remember in COVID-19, the president used to tell us, protect your men, the mouth, the eyes, and the nose, because that is where the port of entry is. But now here we are saying protect your mucous membranes when you're dealing with an infected person, and of course the susceptible host. So this is how you understand, and you be confident on what to do, that it will stop whatever organism or infectious agent that you have. Next. Yes, so next. Yes, so how do we prevent this transmission chain? And remember, these pathogens, some of them we know, sometimes we don't know. For example, you cannot look at me and know whether I have bacteria in my blood or I have something on my skin. So what do? We apply what we call standard precautions. And standard precaution will always prevent the mode of transmission. Now, because people don't come shouting, I remember there's one of the senior doctors who once said, maybe we should label people with HIV and put a mark so that people can always know this one has HIV and they avoid it. But of course, it was inhumane. So what does that tell us? That we should apply these standard precautions for every patient, irrespective of whether the patient is the CEO of the hospital or is the janitor, irrespective of whether the patient looks very high class or low class. We apply them for all patients, and it is at all times, because we never know when we are going to have an outbreak like Ebola. But if we are always having our guard high, then we can be able to prevent ourselves from getting sick or getting the organisms in our bodies. Proceed. So now we go to the topic of interest, which is the Ebola virus. This is giving you the pictorial appearance of the Ebola virus, but don't worry so much about this picture. Just pick one thing that Ebola has a lipid envelope. So lipid is like fat. And guess what? This lipid envelope is easily destroyed by soap, chlorine, and open environment. But if you ask me how long the Ebola is going to be on the open environment to be destroyed, it is hard to know because you're not going to just look at the open environment and say, now it is 20 minutes, let me now go in. So what do? Use soap and water. And use soap and water as many times as you can, because we are saying this lipid envelope can be destroyed. And if you don't have soap and water, you can use chlorine. But I feel that is like somebody saying if you do not have posho, you eat cake. So I think soap and water is much cheaper and less irritating than chlorine. So that is the gist of the matter here, that Ebola is a good virus because it can be destroyed by our soap and water. So how is it transmitted? It is believed that the fruit bats of the family, which is Theropodidae, don't worry about those names, they're just scientific names, but just know it's a fruit bat, which is the natural host. But because humans, the human-animal interface has really gone far, and now we are evading, we are going into the animal world, we are going into bushes, then we end up getting in contact with these bats. Sometimes they eat on two fruits that we also, share with them. And this is how it is introduced through the human population, either through the blood, the secretions, and the organs. And now, after this, we have interhuman transmission, and this is where we normally have the overt outbreaks. So this can occur either through direct contact with blood or secretions of an infected person, mother-to-child transmission, or exposure with contaminated secretions, such as needles and surfaces. So the first one, of course, direct contact could be the immediate family or the healthcare worker. Mother-to-child is obvious. Now, the exposure to objects is where our janitors, our drivers get infected sometimes, and of course, even other professionals. So this is just showing you we are having, of course, from the fruit bat, sometimes it goes into the monkeys, and then when these have contact with the humans, where there is exchange of body fluids or contact, then you have human-to-human transmission, and of course, the reproductive number is quite high, then you get an overt outbreak, as you're seeing. And you're seeing the outbreak doesn't spare man or woman, children or adult. Next. So what are the symptoms of Ebola? Now, the symptoms of Ebola are symptoms that are very non-specific. And even in settings where we have very good physicians, it is not uncommon that we can miss, especially when we do not have an outbreak. Currently, we know there's an outbreak of Ebola, and we know it is really in maybe the people of Congolese origin or people who have been to Congo. So you can suspect, but on a normal day, the first stages of this include a fever, body weakness, headache, joint and back pain, muscle pain, eye redness, and skin rashes. Now, this is very common. It is what can happen for any other disease, including malaria. Then we have the intermediate signs and symptoms, which include the first stage symptoms, plus diarrhea, abdominal pain, vomiting, and dysphagia or pain on swallowing. And then, of course, we have the advanced stage, which has bleeding, mental confusion, rapid breathing, convulsions, and loss of consciousness. But you realize that the patient suspected of EVD, mainly in the first stage, like I said, are difficult to distinguish from other types, like malaria, typhoid, or bacterial infection. So what is the take home? One, we need a high index of suspicion, especially whether we have an outbreak or not. Number two, ensure that you screen inpatients and outpatients, especially when we have an overt outbreak. Do a risk assessment and guide the infection prevention and control precautions to ensure early identification and care of these patients, and then patients and self-continuity of essential health services. But, of course, remember that we said that because these symptoms are non-specific, even other outbreaks, for example, other viral hemorrhagic fevers could mimic this. So what do? Apply the standard precautions all the time, so that even if they tell you this was an Ebola patient, you don't have a lot of anxiety because you know you have applied the standard precautions. I mean, you have done the things that we are going to talk about under the standard precautions. So, when it is Ebola, on my right, and I think also on your right, you're saying something is saying it involves you. And if it is involving you, it could be you, the nurse, you, the doctor, you, the cleaner, you, the scary, you, the admin, you, the accountant, you, the patient caretaker. So what does that mean? Identify, isolate, and rapidly notify the Ebola cases, but most importantly, standard precautions. And I want to overemphasize this. This is for all patients. And the standard precautions, we have hand hygiene. Now, hand hygiene, I told you we can use soap and water, we can use the chlorine, but we can also use the alcohol-based hand washes. So all that time, there should be no situation where we don't have hand hygiene services in our facilities. Then wearing personal protective equipment. And of course, even when you don't have an outbreak, we expect that a nurse has their uniform, a doctor has their uniform, a janitor has their uniform, especially when they are going into patient care. Then you put on gloves when you're handling patients, especially patients who are very sick, you're taking off blood, you're getting in contact with body fluids, irrespective of what the patient has. Then injection safety and sharps injury prevention. Of course, we have our boxes, we shouldn't overfill them. Then the safe waste management. I hope you're all aware that we've had a revision of our waste segregation guidelines, and we have eliminated the yellow bin. Now we have 3 bins, that is the black, the red, and the brown, which is the toxic. So of course, everything that has touched a patient is now infectious. There's nothing like very infectious and not very infectious. And then proper linen, environmental cleaning and sterilization of patient care equipment. Of course, being recorded. The proper linen, this includes linen that is the nurse's, the doctor's uniform, but also the patient linen where it is provided. The environmental cleaning, how do we supervise our janitors when they are cleaning? Where do they clean first? They should be cleaning the clean area first, then they go to the dirty area. And they should use soap and water routinely, unless there is physical body fluid, which they have to first remove, and then they clean with soap and water, and then they add the jig. Not to start with the jig and just pour on say, the vomiters, and then sterilization. And we must make sure we monitor our sterilization process to ensure that we have reached sterility. We have the chemical indicators where we put the tape, and you see it has lines, and those lines change color from green to black usually. Or we can use some biological agents, and we package in the sterilization process. And if they have died, then we know that even the sterilization has really killed all the germs. Then we have respiratory hygiene, especially where you have either you, the health worker, or the patient has a respiratory illness or anything that induces aerosols. Then risk assessment to determine which patient needs more. For example, if the patient has diarrhea, then you need to do the fecal oral even more. So these are standards. And then next we have the transmission-based. Now the transmission-based come in usually when we have outbreaks or known diseases. And these are precautions which are additional to the standard precautions. They include the droplet, the contact, and of course the airborne precautions. And then finally, we have what we call engineering controls and administrative measures. The engineering controls is just having an environment that favors infection prevention and control practice. where you have a one-way movement of patients. You're not mixing the coughers with the non-coughers, the septic with the non-septic. And then, of course, administrative measures, which include trainings like this, to make sure your staff are always oriented. You don't have to wait for Ebola, then you remember. Oops. So in terms of hierarchy, somebody was asking about the hierarchy. So what do we do when we are having controls? The first and the best is to eliminate. And of course, when you know that you have a problem, the best is to eliminate the problem. And how do you do this? You can physically remove the hazard or screen to reduce number of entry points. For example, you remove the hazard by, if you know this is the caterpillar that is causing me problems, when you kill it, problem solved. So if we could identify the bat that has Ebola, you kill it and case is closed. If you don't do that, you can screen. And when you're screening, you want to make sure that every patient who has maybe Ebola is put aside so that they don't infect others. Then you reduce the entry points. And here, the entry points could be those points that are going to bring in the sick people or the ones that are going to make sure they cause you problems. And then finally, you reduce the number of visitors. So this is the time to limit visitors in our hospitals. Then the next one is substitution. Find alternative ways of providing care that reduces the potential transmission. For example, if we are palpating every patient, we can say when we have such a problem, we don't palpate every patient, or we substitute whatever we have with whatever can reduce the potential transmission. Then engineering controls, we talk about the physical barriers, restricting access, and restructuring staff and patient movement. And I think you have seen this in most of our hospitals now. Then administrative controls, change how people work, use standard operating procedures, train people, and modify staffing ratios. If this is the time where you sometimes can call on maybe some nurses to be at the triage, at the screening area, you have the SOPs, all those administrative controls, and this is where the hospital administrators come in a lot. And then finally, use the standard, that's the personal protective equipment guided by the risk. If you're just taking off temperature and you're also at the gate, then you don't need to don like you're going inside. But if you're inside, then you put on the full PPE. So in terms of screening, triaging, isolation, and notification, many people will visit your healthcare facility, some with Ebola symptoms. So to protect yourself, screen patients in a designated area before they enter the health facility. Then isolate those who are suspected. Of course, we have a case definition, and you look at the signs and symptoms, you look at their travel, and you look at it, that what is in this patient that potentially makes them Ebola suspects or COVID or whatever outbreak. And then finally, notification. And of course, the notification starts with notifying the patients themselves. So you say, according to the signs and symptoms you're having, madam, I think we need to rule out that you do not have a disease like Ebola. Kindly sit aside as our team works on you. And then, of course, you notify the high authorities. So this is very important. Start with the patient, allay the anxiety, because no one wants to hear that they are suspected to have Ebola. So don't say you have Ebola, but say, we have signs and symptoms we have seen in you that require further assessment so that you can allay the anxiety as well. And in screening, observe the patients by doing non-contact. Remember, you're not in a full PPE. Do a temperature, usually using a gun, a temperature gun, and ask some questions. And you don't ask leading questions. So you are Congolese, you're from Congo. Of course, the person will deny. But if you ask in a way that makes them answer, then they will answer. And then you don't have to have physical contact. This is not the time to touch. Then triage, you ask the patient to determine the severity of the illness and prioritize care. Simply because I'm an Ebola suspect, I shouldn't die because I'm not being triaged and being given the right treatment. So even as we are doing this, we should make sure that we preserve life. And you must make sure you determine how sick am I, even if I'm a suspect. And that this determines your preparedness to handle the very sick and the mildly sick. And this one likely requires close contact. So while a screener might be putting on just basic IPC, the triage nurse or doctor will be putting on a full PPE because you will require physical contact. And then, of course, isolation is separation from other people to reduce the risk. And here you're transferring for testing and further care. And the patient care in isolation area likely requires close or physical contact. So again, you put on a full PPE as you will have in the demonstration. So as you can see, that is a demonstration of a good screening practice. The person is not putting on so much. You don't see them in the full Ebola suit. And it identifies individuals that meet the case definition. It should be done at interest. And here you're assessing for symptoms and exposures, basically. And who should be screened? It is everyone. Sometimes we have a tendency that the people who come in vehicles are not screened. Then those ones who come on foot are screened as if Ebola knows a vehicle. So we should screen everyone. And the setup, you see you have the entry. The staff may be entering from a different area, but they should also be screened. And the staff should have where they exit from, even the patients have where they exit from. And then it should also be clear when you have a contact, don't just be there and say, hey, now this person is likely going to have Ebola, and then your staff, you don't even know where to put them. They should have where to be put, and you should know who to contact next. And you should have enough space at the waiting area. There's recently a place I went to where we were in the waiting area. Then I was being screened. There was another person who was being screened. Another person was very sick. The nurse just got confused and stopped working and looked at us because she didn't know how to handle the emergency, the routine. And then people were complaining, you want us to get sick. So have a plan and have a sort of like imagination of if I don't have. And then it's also not uncommon to have people who want to use the latrines or the lavatories. Have a plan for this in mind. Should somebody want to use a latrine or a toilet, where do they go when they're still being screened? And if this is before they go to the maybe isolation, then the person who is dedicated to clean it should also be aware that this one could be handling suspects. So these are just examples. Continue. Okay, maybe just a little on the last picture. I think yes, you see that nurse is trying to screen, but he's almost putting the gun on the patient's ear. And that should not be the right practice. It should be at a distance, but still capture. And then there should be a barrier whenever possible. Not as part of isolation, but you don't want a patient, for example, to vomit or to collapse and just, fall on you. So you have that barrier. Proceed. Then using an infrared thermometer. Now we have used this, and again, in one of my travels, I went to a facility where they told me you have a temperature of 32. And the askari was very happy. He's like, no, madam, you're okay, you can proceed. So the thermometer has a range. When you have anything less than 35, please retake. Sometimes it even shows you it is not human, maybe it is surface. So sometimes you have got it wrong, but a temperature less than 35 is preferred you repeat or you retake. A temperature between above 35 up to 37, maybe 0.5, then that is okay. And when you have 38 and above, that causes a reason to alert management that this is potentially, because you know that this being a viral infection, it really gives very high temperatures. So anything 38 or higher, then that is a person who has a fever. If symptoms of fever and exposure criteria are met, notify the supervisor. and escort the patients. Then we have some other caution, read instructions for calibrations. I know everyone sells these temperature guns, and you have to make sure you change the batteries. So if you have the biomedical engineering department or geoengineering department, they should make sure they calibrate these. Because if they don't, then you keep getting temperatures of 32, and then the SCARI will tell people go in. So this is very important. So using the screening algorithm, no symptoms, no exposures, you continue with the healthcare facility. But if you have no symptoms, but you have exposures, have the person wait outside the facility, and then you look for the contact tracing hotline. Then if there are symptoms but no exposures, again, move to isolation or holding, and that is a low suspect patient. But if you have both, then this one goes to the isolation or holding area. So usually where the challenges come in is the number 3, where you have symptoms but no exposures. Because sometimes if you do not handle it well and you make the 2 people mix, the number 3 and number 4, you could end up having somebody with symptoms that are non-specific get contact with the potential patients. So there should be efforts to take off a sample or to further assess without having number 3 and number 4 meet, because that is another critical area. And then the PPE, we have a job aid, we have a Ministry of Health, IPC, and other risk assessment charts or job aids. I will give the link to the team to start health workers. It's really for health workers, and it is something that you should. So that job aid gives more about PPE for screening. But if you cannot, if the screener cannot maintain this distance, for example, you need to assist the patient, then the PPE to put on is to protect the person from risk of exposure to blood or body fluids. So this is very important, especially when you're screening, things can go haywire. So you need to be prepared, and you have the PPE very near. So then we have the healthcare facility holding area. Here you identify, isolate, and inform. This is really okay. You see? And then the isolation area setup, which should be separated from patients for Ebola suspects, and the equipment should be designated and should not be shared. You see? This is really about the setup. It is something that I've already explained. You see? And this is just an example of an isolation area. It could be outdoor or indoor, and it is for temporary use until you transfer the patient. Then the supplies you need, as explained, for the patients where possible in the isolation area, and then the patient care. That is also catering for the patient care, the cleaning and disinfection, and then the waste management, and then personal care. Then this is in the isolation area. Again, we have a job aid A, but this we are going to go through physically or practically. Then for notification, where we are informing, proceed. Who do we notify? We have a toll-free line for Ministry of Health, but you can also notify your supervisor or the district surveillance point of contact in case you're not at the center. There's a district rapid response. So the DHO's office should have a surveillance officer, but also every facility should have a surveillance focal person. Then PPE for EVD management, this one I will not go through because they are going to go through it again. But what is, just a minute, the principle is PPE is less effective, is the least effective safety control if used in isolation of engineering and administrative control. So you're not going to say, I have my PPE, then you do not have, like, you're squeezed, you're almost hitting each other, and the success depends on the enabling environment. You must do it to learn proper PPE use is a motor skill. And safety considerations: never touch your face while using it. Change immediately if it becomes contaminated. Do not adjust during patient care, and if there is concern, leave the patient care area. These are charts that you will get when you get the presentation. And now finally, I want to talk about the obstetric department. This is an area where people usually think they are not concerned about the precautions, but remember, risk screening in the obstetrics department is indicated, and you must use the standard PPE for delivery. Remember, you're going to get in touch with the body fluids. And remember, bleeding is a final stage for people who have Ebola, for example, but that is for normal patients. But you don't know whether this person is bleeding because of their maternity problems, obstetric, or it is because they are having Ebola. So you should be very conscious, and you should rescreen all pregnant women, not to make sure that they have EVD, but also because of the risk that they carry when they are pregnant. And this is just the PPE that you use. And what happens if the patient has Ebola? For example, a mother has Ebola, they don't have to spread this Ebola to the baby. So you also have to make sure that you're also conscious about that. So the hand hygiene, they're going to demonstrate as they're doing the PPE donning and doffing. But yeah, you can use soap and water or the alcohol hand-based rub. Or you can use the weak chlorine, which is 0.05. And these are your 5 moments. Again, these ones, they will probably go through, but you need to, I'm sure many of us have these charts of the 5 moments, but when we are not in an outbreak, we forget them. But we have the 5 moments, we have the charts for how to hand rub and hand wash. Yes, proceed. And then we know how to handle the sharp. You do not recap, you do not overfill, and you do not, you protect the exposure of people. Then finally, cleaning and disinfection. This one I've already hinted on it. Same about the environmental cleaning, stepwise. And then we have the old practice where we are spraying, but we are saying that this Ebola is contact, and it drops on the equipment. So when you spray, the environment doesn't have, it's not an airborne where you're having the Ebola in the environment. So no spraying is the new practice. We actually clean the surfaces where the Ebola virus can spread. So this is very important. Then the waste management, here the most important is domestic waste and infectious waste are not put in the same, but all waste from the Ebola treatment unit is managed as infectious in case you have. Safe and dignified burial, there is an SOP. And then the inpatient surveillance during an outbreak, that one also has an SOP, and it depends on the incubation period, which is 2 to 21 days, and the average is 7 to 10 days. And here you're just every day looking at your patient to see who might be having more fever. You apply the standard precautions, take temperature at least twice, assess the patient once a day or immediately in the presence of a high fever, and complete the screening register. And that is the example of the screening register. And then you identify, and then you further investigate. Ebola is not, finally, before I go to the ring, Ebola is not tested in clinics. Let no one lie to you that we have a clinic that tests Ebola. Ebola is tested through the Ministry of Health authorized laboratories, and it is through that IPC, surveillance system that you'll have somebody tested for Ebola. So let not no one say that I went to a clinic and they tested me and I don't have Ebola. The ring is really when you have a patient, and it is just about the approach where you rapidly mobilize teams to assist the affected health facilities and the community. And this is more about the ring, who is affected, which radius. We have the 2 kilometer and the 5 kilometer. And then, of course, the health work assessment or readiness check. Yeah, these ones we've talked about. It is just re-emphasizing. Proceed. So the take home is IPC implementation. We have the screening and isolation protocols, the hand hygiene, the PPE, environmental cleaning and disinfection, but it is important to train all staff. Ongoing monitoring is also very key, and ensuring safe and dignified burial and supporting IPC in community settings. So this is very important. It's a very big topic, but at least when we leave you with this plus the link to the slides or the support material, we hope that you can read it, be confident to handle the patients. Thank you so much. And these are the resources I've been talking about. These are all the job aids that we have, and I'm going to leave the link behind. So thank you so much for listening in, and the link is actually there.
Okay, thank you, Dr. Ambilu. That was a very thorough conversation, and I am hoping all those who have joined in when we already started, you have gotten a glimpse of the topic, which is IPC, Guinea and Ebola outbreak. And at this moment, I would love to invite questions from the conversation that we just had. There are a couple of questions that came through the chat, but were responded to. But allow me to re-echo just two of them. There was a question about the procedure of ambulance decontamination, and our specialists already responded to it that you need to follow all the steps. One, using the appropriate PPE, then risk assessment, then you follow the step of cleaning with soap and water, rinsing with clean water, use of chlorine 0.5%, and this allows contact for a minimum of 10 minutes on the surfaces. Then rinse again with clean water, allow the ambulance to air dry, and always clean from top to bottom, inside to out, clean to dirty. That for me is very important. Top to bottom, inside to out, clean to dirty. And you also follow the other SOPs as you remove the PPE, following the BADE system. So that is very thorough, and I would love to ask anyone in the chat who has a question, please raise your hand, and we can ask Dr. Nambilu to clarify in case any of the components of the presentation were not very clear. As we take the questions, we are also now preparing for the physical illustrative session on PPE donning and doffing. For those who have been asking about it, we are going to see how it is done. But yes, I can see there is a hand from Marion Komgisha. Let us unmute Marion so that she can ask her question. Oh. Yes, Marion, you can ask. You're unmuted now.
Yes, good afternoon, team. Thank you for the training. And my concern is about the PIDs, that majority of the time they come in when they have fever. So I would like to be taken through. I know that we are screening at the gate, and fever is one of the signs and symptoms that we look out for. And we have received quite a number of them. They have fever, but they don't have any other like linking, sign and symptom. However, because our guards are up, we are really trying as much as possible to ensure that we don't spread just in case there was any risk. So kindly take us through how the PIDs, we shall handle the PIDs, who majority of the time will be coming in with a fever.
Okay, that has been well noted. we can take the second question and answer at once. Joseph Egiru, sorry in case I'm mispronouncing the name. You hear me? Okay, yes, Joseph, please unmute. Okay, Joseph is not speaking, but I can see someone in the chat saying you talked about district surveillance teams. It's very painful that I tried to contact them recently. There are many referrals to talk to this, and all the 8 people told me how they could not come to where the patient was, and the one who tried told us to take off the blood in a vagina, it would be picked like in the next 15 hours. Yet the patient had been vomiting blood for 2 days. What is your comment on that? I think Dr. Namwili, you can take those 2. And yes, Dr. Kagali Samuel, so that we conclude with the questions. But keep the questions coming on the chat, members. Yes, Dr. Samuel? Dr. Samuel?
This network.
Joseph, we can hear you. Please go ahead.
Oh, thank you. Thank you so much. Good afternoon, team. My name is Joseph Egiru, as indicated, and a comprehensive nurse by profession. I'm currently working in Kamwenge. My question is simple. One, we have the outbreak of Ebola, but we have also been running some searches about the strips for testing for Ebola. We've gotten to know that the strips are available. What is the reason as to why that Ebola is not tested in the private facilities or clinics? And yet, we are in to identify the situation and probably would make a referral on a timely manner. But if now we are just basing on theory kind of assessment of a patient, and then we refer, maybe isolate, it would be good for us to test and then probably proceed with the other SOPs while looking at referring the person for treatment. I would request for your more light on this. Thank you.
Okay, thank you, Joseph, and allow us to request our experts to respond to those questions.
Thank you so much for the wonderful questions. It shows you've been really paying attention. The first question, there was a question about how long does Ebola stay in semen. So studies have shown that it is up to 3 to 6 months. Some studies have even been documented to take longer. Usually after an outbreak, we enroll people into a cohort and we follow them up to know how long it stays. But so far, up to 6 months, we encourage using extra precaution or protection so that we can be able to be Ebola-free. The issue of the district surveillance focal person, that is quite unfortunate, and we truly apologize. I don't know the district, but maybe what is important is we are also going to share the Ministry of Health hotline, but you can also send a message on 6767 and you put the alert, and usually the Ministry of Health desk can also be able to pick it up and follow up also with the surveillance focal person. So we shall share that also so that you can use. We have like 3 options. We have the hotline, we have the code, the QR code, and we also have the 6767. Then about the private clinics testing, Ebola is a high consequence pathogen. And for anyone to test Ebola, it requires a level 3 biosafety measure, which is not something that we can get in many healthcare facilities. So while we want you to be able to identify early, we also don't want you to put your lives at risk. So currently, the labs that have been certified and have the right precautions to do this are only the labs in the government facilities, and not even just any, but the labs in under the Department of Lab, that is CPHL, UVRI, in a coordinated manner. But if you really feel your laboratory has the safety precautions, you can always engage the Department of Lab and Diagnostics at the ministry, and then they assess you. But for now, we cannot afford to just put everyone's life at risk. And also, remember, we keep getting different strains. Now we have Bundibujo, last time we had Sudan. So it is not something really, it is the mandate of the government, and that is what the government is doing for now, unless we really get out of hand, and then they assess and equip the private laboratories. Thank you, and I hope I've answered everything. Oh, the pediatrics, yes, of course, not everyone who has a high temperature, even if it is adults, is going to be called an Ebola patient. Like I said, we have a checklist, and the checklist is as per the case definition. So when you look at the checklist, you'll know that even with a high fever, we don't regard you as an Ebola suspect unless you have met the other criteria. So when you look at the job aids, there is a checklist for screening that we look at, and when you meet it, then you can be able to be regarded as an Ebola suspect, and then you alert the surveillance teams, and then they will come and proceed with the next steps. So don't just suspect everyone with a high fever without taking them through the checklist. Thank you.
Thank you very much, Dr. Sauda, once again. And at this moment, allow me to introduce our next experts, Dr. Charles Tambi, who is an IPC specialist supporting the Department of Clinical Services at the Ministry of Health. Yes, he's going to come and you'll see his face. And alongside, he's going to be with, yes, so Dr. Charles Ntambi is here with me. Let's get down. Okay. And next to him is Ms. Comhendo Judith Jolie, who is an assistant nursing officer with the Mulago National Referral Hospital. So they're going to take us through the physical process of donning and doffing the appropriate PPE during the Ebola virus disease. And let's all listen and learn. Keep the questions coming. Thank you very much. So for those who have just joined in, this is an EMS Echo session that is being hosted by City Global Health in partnership with Ministry of Health, Department of Emergency Medical Services, and it is a timely presentation about IPC, where we do believe that in an outbreak like this, protection of both the health workers and our loved ones is a fundamental responsibility. So as the team prepares to start, I want to re-emphasize the importance of following the standard and let alone the transmission-based precautions. So we have those standard precautions which we should always at all times be practicing. And then we have the transmission-based precautions, which we switch on during a particular demand, like now in an outbreak like this. So for those who have been asking whether we should put on our face masks to stop Ebola virus transmission, it's part of your standard precautions as a health worker as you're attending to patients. Okay, so at this moment, allow me to switch our videos. And for those who are in facilities where you wanted to learn how this is done, this is the best time. So it's going to be a physical illustration using the PPE, and feel free to ask the questions in case either the video or the audio are not clear, but we hope everything will be okay. So at this moment, allow me to hand over to the team to take us through.
Yeah, thank you so much, moderator. Before we start our training, we know that donning and doffing is also crucial as far as IPC is concerned. We are going to introduce our items, what we have here. We have our checklists, but I'm together with Dr. Ntambi. Dr. Ntambi is going to be my birthday. We always emphasize bidet system. So we have our gumboots. We shall be able to use the alcohol as we start donning. We have our gloves, 2 pairs. We have our goggles. We have the head cover, for example. We have N95 mask. We have a Tyvek or cover roll. We also have the apron. We do apron with 2 types of aprons. We have reusable and disposable ones. We have also a head cover in case we have a long hair. If you have the short hair, we don't usually use it. In here now, we are going to start donning. We want to emphasize the budget system. I'm going to be the instructor. He's going to be the one donning in. So Dr. Ntami, you're welcome.
Yes.
We are going now to don in. We are going to see our patients as routinely. So we are going to don. Feel free. I hope you have eaten something.
Yeah,
You've taken some water.
I'm very okay.
You have visited the shower rooms.
Yes, I'm very
So we are good to go, members. Do you have any phone with you?
No,
Check around. You have any
gadgets.
don't have money? We don't go with anything. It's one of the resources of it's a resource of infection. So we're going to use, we have different options as doctor has mentioned, but we're going to start with alcohol based for rubbing as we're going to don. And as we're going to doff, we shall use chlorine 0.5, well with gloves. As we proceed, we shall use chlorine 0.05. So let's begin by hand washing. We are going to hand rub. We start and bend a bit. Are you okay?
Yes, sir.
Yeah, feel free with us, please. So the good clinical practice, when we come from home, we come with our street clothes. We call them street clothes. Now we have changed to the scrubs. We are supposed to have the separate rooms for donning, for privacy. So Dr. Ntambi, pick your gumboots, go and change to the gumboots. The gumboots are here. You see now he touched his gumboots. We're going to perform hand hygiene. We're going to hand rub, Dr. Hand rub. Bend a bit. So you make sure that the hands are dry. We are drying it by air. We don't use towels in this scenario. So pick the first pair of gloves. Usually we prefer having the same color of gloves. So in case of any spill, it is easily being seen or identified. And in this, we prepare things according to our sizes. Make sure the hands are dry enough. They've dried up.
So take your time.
Also here, there's no rush. We agree that there is no emergency in such situations. Relax your mind. Make sure whatever you're putting on, it is the right size, and relax your mind. Take your time, don't rush, and be calm. So you can see he's calm, he's relaxed, ready to go in. So now we are going to put on the cover roll. The coverall, we know that they're in different colors, different, made from different factories, and they're in different sizes. So doctor chose his size which fits him. But before that, the good clinical practice is to check it. Doctor hold it and check it in case of any factory error. We don't want to regret after putting it on. We say that some coveralls, they come when they are complete, like the one doctor has. It has a wood attached to it. There's a zip. Everybody is able to see the space there. Has a loop attached to it too. We shall see it better when we are donning in. So preferable, if you cannot stand, you can sit. It's allowed, you can sit so that you are comfortable in whatever you are doing. So he's seated. Slowly. We are saying be calm and cool, relax. We don't want to regret after. Doctor, are you okay?
Yes, I'm very.
We embrace the body system. You know, you keep company with your body. You keep counseling your body. So, my body, are you okay?
Yes, I'm okay.
That's good. Are you happy?
I'm happy.
That's good.
Yeah.
Can I assist you?
Okay.
It's okay.
That's good. Then go for the rest.
So he's done with the first leg. Yeah, we are still donning. We are donning. We are on the coverall. So the coverall, we call this one a loop. Its purpose is to make it makes the coverall firm on you. And I'm going to show you in case you don't have it, what are you supposed to be doing? In case it didn't have it, either it can go backwards. You can see the exposure, or it will cover the whole hand. Just imagine a red zone, for example. So without the loop, we can create it. But this one has,
So we can cut.
we usually cut with a scissor, depending on the size of your finger. So you make sure it is fitting. It is fitting. So here we're supposed to check. You can turn doctor and see. You're able to bend. Because when you go inside there, you do all sorts of work. At least now you can see that it's flexible, he's free in it. And we discourage fitting in this scenario. Yeah, let's now put on a zip a bit. We're going to zip a bit. This is a mask 99. It has 2 strings. N95 it has the 2 strings you can see. Hold it as I'm holding it. Make sure the strings are closed. So you're going to bend a bit. Bend a bit, but before you bend, allocate the lower string. Bend and never touch the inner part of the mask. So pick the lower string. Whether we're supposed to have a dressing mirror in here, but without a dressing mirror, the body does it. And we don't want to pretend. In this, there's no expertise, right? We don't want to assume that you know things. No. We do things by, there must be a guide. And we're supposed to have these procedures hanged around. So you can see how we put on the mask, for example, is smart in it. Now the next procedure is we're supposed to put on the goggles. The seal check that the seal is really fitting you. and is able to breathe. Are we together? So these are the goggles. Also, we have goggles in different colors. But before you put it on, usually it fogs. We have what we call anti-fog. But for us here, what we use without anti-fog, we use liquid soap. It is better as before you start donning, you clean them. You clean them with soap. Clean them. Take your time to clean them in and out, and then you put it aside so that it dries well. And never use alcohol. When you use alcohol, it keeps choking. Just imagine you're in red zone and you are coughing. So doctor, please, I've cleaned your glasses, your goggles, put them on. Some people sometimes ask, suppose they have glasses like me. It is important to clean your glasses. They call them medical glasses. Then on top of them, add this. So doctor, you're going now to bring the wood. Bring the wood. You make sure it's not exposed in any way. So the back. So this is a seal. You make sure that you lock it. You lock the zip. It makes that noise. This is a seal. We don't usually open it, just open a small portion. Then, so this one will assist you when you want time for doffing. You just pinch here and open. So the next step is going to be the surgical glove, Dr. Charles. After this one, let's put on let's put on the apron. Aprons, we said there are two types. You have the reusable one and disposable ones. Reusable ones and disposable ones. So sometimes the bidet can assist you to put on the gloves. You make sure it is really fitting and the coverall is inside to avoid any spill or water to drop inside there. Don't rush. Don't rush. You know, it can easily get a hole, and for you, just go in. Make sure the glove you have, it's a rich size. We don't want fitting. It shouldn't be too flabby. It shouldn't be too tight on you. So you make sure that it's tucked inside the coverall is inside the glove. So the last tip you have is going to be the apron. Doctor, put on the apron. Okay, this one. Let's go this one. Are you okay? Yes. Good to go in. That's nice. Good for you to try. This one is better you tie it yourself. Reason being, the same for doping, nobody is going to touch you. By that, but the system stops here. In red zone, it doesn't work much as in doping. Wow. So now we are done. We are supposed to write his cadre, his names, and time of entering. And I guess by now we should be knowing the reasons why. One, why am I going to put Dr. Ntambi? If I didn't see him putting on, or I wouldn't know that he's the one. Even the patients we treat, whether they just identify us by our names. So this is Dr. Ntami, you know. So time, we have started time was supposed to spend inside there. Those are 3 hours. So when you are in, you keep asking yourselves, time, you get it? Kada, we say the doctor or a nurse, we have different roles inside there. When you go inside, a doctor maybe a nurse. Let me pass right here. Time. Goes to 3 So we are saying patients identify us by reading on us. It's better you write in front and behind so that you can be accessed in any angle you'll be in. Now we are good to go in. We have a checklist. Of course, we have written who is going in. That is the ideal. Write all the members who are going to enter. The time they entered. In case of any exposure, this list will assist you to trace them. So I've written behind here and in front. I've told you that it is so that you can access me whether I'm standing this side in any angle. You're able to call me. So we are good to go, doctor. Let's have a prayer. So we call upon you, lead us, give us skills and knowledge. And I was going to treat our patients, Lord. I will pray this to the Lord. Amen. Let's have a good clinical practice to be praying from today. So remember, this is the dawning area. We need to pause. One question. Yeah, pause. So we are okay, let's pause.
Okay, members, I hope we have all been following, and at this moment, I would love to call to ask questions on this procedure that we just had of donning, at least up the point of donning, before we go to the part of doffing. Do we have any questions? How can CDP points be okay? How long does one take? Just open that again. How long does one take in the protective gear? Okay, so our experts, would you want to answer that? How long should one take when you are wearing the protective gear?
So we are saying standard 3 hours.
Okay.
Yeah, standard 3 hours.
Okay. And if I feel uncomfortable within those 3 hours?
Automatically you report to your body and the supervisor inside, then you exit.
That's very important. Please don't start touching your face or removing the face shield in the middle of when you're still donned inside. Once you feel uncomfortable, you'll have to move out. That's why they advise us to first, pee, make sure we have left all, phones and wallets outside, which can shorten our stay inside there. Okay, the 3 hours spent in the treatment room, can someone suffocate while they don inside?
Of course, it cannot if at all you are really prepared.
Okay.
You need to counsel yourself, mentally, socially, and physically.
Okay.
Then you're good to go.
Okay.
Relax your mind. Just know that IPC is the only way to go.
And if someone has respiratory complications,
you don't allow them to go in.
Okay, that is a red flag. I hope you hear that, members. Please don't enter when you have the complications that may may be exacerbated by this tight PPE. Now, there was a question of how do we dispose them off after after interacting with the patients. Let's assume there are many in the room.
We usually go with the hygienists.
Okay.
They enter frequently to check, then they bring them out. Hygienists.
Okay.
Yeah. We don't keep them, we don't follow them for a long time. We keep going with them, they clean, then we start off. Okay, so members, I hope we are all, and if I have a huge beard, is it recommended for me to first shave before I don? Yeah, you see, when we talk about IPC, we don't take risks. If you know that the beards, the disturbing, just be aware with them. Shave them. When the outbreak is done, they will come back. Okay. What is important, the beards or the lice? To me, I will just remove them off. When the outbreak is done, I start to stop from. So for those with tall hair, with beards, with dreadlocks, which are not going, with sharp nails, and outbreaks, all those things, we don't move with them. You get it? Okay. Here we have so many styles of hair. Okay, sister. Either you can cut it off or you can restyle it. Restyle it. As long as you're not exposed. So members, I hope that is very clear. The nails, cut them off. Okay, we cut the nails, we shave the beard, we trim that hair. Sister has assured us that it will regrow kabisa. Don't get so worried. And at this moment, let me see, do I need to put on Pampers to an Ebola suspect patient with diarrhea before evacuating him with an ambulance? That would be the ideal. Okay. That's the ideal. And we do, by the way. Okay. We do. What's the question? Do I need to put Pampers on an Ebola suspected patient? Yes. With diarrhea? We do, even right now we do. Okay, but also with the right PPE, you know? So you PPE? You don't need a full PPE to go in red zone. To go to the red zone. Yeah. As you not do the nursing care. Okay, last two questions. For one reason or the other, if a health worker collapses in the treatment unit, how do you go about it? I think let's first off. Okay. Then we shall answer the remaining questions. It's my question, the most question I give them. Okay. Now they want me to answer. Yes, and that's the next question. How do you undress those PPEs? So, members, now let's go to another important part of doffing this PPE or this PPE, and we shall answer all the remaining questions by our experts once they are done. So, eyes on the camera one more time. Thanks so much once again. Remember, we don't, now we're going to doff. And we know that it is time for doffing when health workers get infected members. So in front of us here, you are seeing different containers. We have a basin of 0.5 chlorine to decontaminate the gumboot. We have a container for reusable items like this thing. We have another container for disposable items. We have 0 chlorine, 0.5. We shall use it when we have our gloves. In here also we have chlorine 0.05. That is after when we have removed the gloves. We have another base in here of 0.5 chlorine to decontaminate as we exit. So Dr. will be back. So now we have followed the steps. There are quite many, but we have to bear. Step number 1, perform an hygiene. Step number 1, decontaminate the gumboots in 0.5 chlorine. Well, we call it Ebola dance. You can dance Dr. Bit. We don't want to carry it away with the. That's why we have to decontaminate the gumboots. So you can step a bit. So this is the doffing room members. We are in a doffing area. So doctor, now you're going to perform a hygiene using chlorine 0.5. We assume this is chlorine 0.5, no? Benefits. Are you okay? Just relax. Yeah, it's very, very important, members, when it comes to doffing. We agreed that it is this time here where most of us gets the infection from, eh? So when you are doffing, relax, take your time, follow the instructions. So he's done. He's going to remove the apron. And among all the items you are seeing here, the highly infected or the highly infectious item is the apron. Remember, you've been touching patients, you know? It is in front of you. So, doctor, we now are going to remove the apron. You can pinch or you can pull it. Then you roll it in, out, in, out. Remember, the outer part is the one which is highly infectious. So we're going to discuss it here. This is the disposable items container. Drop it there. Get water, chlorine. We are using chlorine 0.5. We are still with the gloves. Yeah, what the beauty part of this doffing, we give it a lot of hand washing. There is no rush in here, team. Relax, take your time. But then they give us another opportunity. If you feel that you are not really clean, you redo it. Our safety is number one. Make sure that we are safe. Thank you. Now we are going to remove the cover roll. But in a real ETU, I'm not supposed to be standing here. Remember, it's from red zone, me I'm in green zone. So, doctor, you allocate the seal. Remember how we close it. Use one of the hands you use best to open it. The left, as long as, so the left dominant one. Expose the zip. Go up. He's going up. He's searching for the zip. Why do we search it for it? We don't want to go around looking for it. Eh? He will be exposing. He will be touching himself. Eh? Are we there? So if he has opened the zip, you know, remember you clipped it, and you do it slowly. Slowly, Dr. Ntambi. So you tilt the head a bit. Stand and tilt your head. Pinch. Backwards. That's nice. That's nice. Now we are going to remove the cover roll. As long as it's fitting you, it makes life easy for you while doffing. If it was too tight, it was going to dance here until all the twins are done. So, doctor, you're doing well. You're doing well. Just keep, as long as you touch the inner part of the cover roll, you're good to go. You step on it, kick back, keep adjusting. Keep adjusting, avoid kicking at once. The gumboot can easily go off. Kick, doctor, relax, kick back, step on it, kick back, adjust, keep alternating. Here you need to relax. Relax, kick a bit, remove the cover on the hands. Remember, we have 2 pairs of gloves. The first pair of gloves is supposed to come along with the cover roll. As long as you touch the inner parts and avoid the spills, remember the exposure. Any slight thing, it will flash on you. Doctor, you're doing well. Let's take a bit. So you bend and gather your cover roll. Dispose it here. Yeah. Drop it here. Yeah, we don't maneuver here. We do the right things. Doctor, thanks so much. You're doing well. We are going to perform hand hygiene using chlorine 0.5. Are you okay? You're breathing well? Okay. I'm not supposed to be a members, but we're demonstrating. If you have the other one for stepping, just step on it yourself. And I'm not supposed to be closer as I am here. Is in red in green zone. I'm supposed to be the instructor, of course, but the distance from him in green zone is in red zone. You're doing well? Yes, thank you. So the second one is going to be, we want to remove the goggles. Doctor, you can bend a bit and you close your eyes. While we're saying that you should close the eyes, any spill will just go into your eyes. That's nice. We have different PPE, I told you. We have reusable and disposable. So put the disposable in the container. Yes, yeah. So perform hand hygiene. Don't get tired of performing hand hygiene. IPC is paramount here. There's no rush. There's no emergency in this. Make sure you're protected, then your patients are safe and the environment. Thank you. Now bend a bit, doctor. You know, it has two strings, the low one first. We're supposed to have a mirror because I'm supposed to touch him. Well, remove it. Remember, you've been performing hand hygiene. Follow, if at all you've been doing it well, you can touch. All right, that's nice. The second one, drop it, discard it here. Perform hand hygiene with chlorine 0.5. Are you okay?
Yeah.
That's good. So you can just imagine how many times have we performed hand hygiene. But is our safety, not so? So we keep on proceeding, not in one step, you know. Now we are going to remove the gloves. Doctor, I'm going to bend a bit. Yeah, it depends. If both of them they're clean, fine, but at least choose the clean one.
So and then inside, outside.
Okay.
So pinch, make sure it doesn't snap. So you can drop this if you are good. Then inside, skin to skin. Inside. Slow. Inside.
Thank you. Now we are moving. Remember, we've been using chlorine 0.5 with gloves. Now our gloves are off. We are going to decontaminate the gumboots with chlorine 0.5. You can see how we're dancing. Yeah, we're doing the shoes. We are moving forward. Now this one is going to be our chlorine 0.05. So we are almost there. We are changing to chlorine 0.05. Or here you can also use soap and water, members. Soap and water can do better if you don't have chlorine 0.05. We are sanitizing also. Yeah, clap for him. Thanks so much.
So we get some water.
So ideally, he has been sweating. is supposed to come and help, but let's say a bottle of water and a yellow banana, or if possible, anything available, you know. He has been sweating, so he's done.
Make sure we do the donning register.
Yeah, so remember we registered when we were donning. Now again, we're supposed to be doing the registration.
Here we are looking for any events that happened in the ETU or during the what? The doffing. So the question which you are asking, what happens if I've fallen inside? We are registering it at this moment. We are doing a risk assessment of if you fail, did the entire gown go off? Did you fall in a suspect zone or in a red zone? So this suffices. Whenever you're in a treatment unit, and remember the treatment unit has positive patient. And remember we said the definition of a suspect is somebody who has had contact with what? Or you will be defined as a contact. So you'll be treated as a contact, and then you'll be taken through the whole process of how contacts are treated. And they are quarantined, and then they're observed for 21 what? Days, because now you are a contact. You become a suspect if you have had contact with that patient and now you're also exhibiting symptoms. It means that during the period of quarantine, if you're tested or if you start to have symptoms, you become now a suspect. So the moment you have had an incident and fallen in the ETU, you cannot go back to normal what? Normal care. You have to be quarantined and observed following the SOPs. Okay? So make sure you're always clean. Now, the people who come and clean the doffing area also have full PPE what? On the way we have been dressed, and they clean it in a reverse direction, taking it back to the what? To the treatment unit.
Thank you, my question.
Okay, I hope that was very illustrative and helpful. And thank you very much, our experts, for the very candid presentation. So I will ask more questions. This moment, we are coming to the closing part of the session, and want to thank all those who have spared time to log in. So please don't go off immediately, because we shall later have the post-test questions. But meanwhile, if you have a question, please raise your hand. And as you raise your hand, allow me to ask some of these that have come from the chat. What is the rationale of putting on gumboots before the overall? 2, how many cases can someone attend to before taking a full body shower? And 3, for now, if the team is big, the clinician initials should be written. Okay, this was a comment. Clinician initials should be written on the overalls. And is there a risk of touching his head as he removes the eye goggles? So perhaps you can first respond to those.
Thank you so much. I'll try to allow my colleagues to answer some. So the first thing was, do I need to put on the gumboots before I put on the overall?
Yes.
Isn't it?
Yes.
So if you have noticed, the gumboot is on the inside. There's a certain part of the gumboot that is we deemed as what? As slightly less dirty than the outside. So if you put on the overall before you put on the gumboots, you're going to manipulate the overall, and you risk it being what? Torn. The other bit, if you have noted, we try to be comfortable when we are putting on the what? The overall. If I cannot stand, I'll sit such that I move very slowly and I do not rupture the what? The coverall. Or if I can stand, and then the other bit which we say, you have to know the size of, first of all, gumboots that you put on. They should not be too small or too big, or else you spoil the coverall. Then you should also know your size of the coverall. The moment you see the gumboots are not fitting in the coverall, it means you're putting on the wrong what? Size. Either of the gumboots or of the coverall. Or you are rushing and you are going to tear the coverall.
Okay.
The other question.
And how many cases should one attend to before taking a full body shower?
So a full body shower is actually at every time when I finish doffing. So by the time I'm taking a full body shower, it means that I have left the treatment unit and I'm able to change into another set of scrubs. And then on the inside of the treatment, I thought that would have been the question: how many patients can I take care of when I am in the treatment unit?
Yes. That's
so when you're in the treatment unit, we always have a number of categories. First of all, anybody that is in the treatment unit is either a suspect. That means this person is meeting the case definition and has symptoms and perhaps is waiting for the result to confirm. Then we also have that set of patients that are confirmed, meaning they're in the treatment unit and we also have their results as being positive. So if you notice in the treatment unit from what Dr. illustrated, it is a unidirectional flow. And the principle of risk assessment suffices. You start from the least risky to the most risky. But you know that a patient that is a suspect can almost turn into a confirmed case. The other bit you have to ask yourself in a treatment unit: do you have a wet patient? Do you have a dry what?
Dry patient.
So you find that if you have a wet patient, you may not be able to perform the necessary hand or IPC precautions before you see the next patient.
Doctor, maybe just pause a little bit. Who is a wet patient and who is a dry patient?
So a dry patient is one who may have all the other symptoms of Ebola, or even has a positive test, but is not either diuretic, is not vomiting, or is not obviously bleeding.
Okay.
So meaning the amount of body fluids the patient has in their environment are very limited, apart from the normal fluids the patient may have, sweat or... Now, a wet patient is the opposite.
Okay.
It either obviously be diuretic, vomiting, or even having obvious hemorrhage. But if you have noted, this spectrum is subjective. The patient can be dry and then they become wet. They can be wet and they become... So the whole principle of risk assessment for a health worker suffices in everything we do. As you're doing as you're moving, so you want to move from the dry patient to a wet patient. You want to work on suspects before you work on confirmed patients. Better if you have enough manpower, another team works on the suspects, another team works on the confirmed cases.
Okay.
But if you have noted, the principle of IPC again doesn't go away. When we are inside the treatment unit, our hand hygiene and disinfection process that we use, all what we use is 0.5% chlorine in the treatment unit.
Okay.
Whether you're working on a suspect or you're working on a confirmed, because we have already the PPE on.
Okay.
And we observe all the moments of hand hygiene, even on the confirmed or suspect. And that is before touching a patient, after touching a patient, after touching a patient's hand, after touching the fluids, before a procedure, after a procedure.
Correct.
And you're supposed to observe the same IPC from patient to patient to patient, but doing a risk assessment. If you're obviously very soiled, it is not advised that you move from that patient onto the next. You're advised to go remove all those material that you have been soiled with and put on a fresh to reduce the risk of transferring infection. And if you noted, she said the team does not only have doctors, nurses, laboratory team, we also have the hygienist team. And the full IPC team that does IPC ward rounds to assess whether the risk is high or low. And that means the whole SOP of environmental cleaning also comes into play. If a place is too dirty, it is first cleaned before the doctors or the team enters. Because even if you have a positive patient, the more you reduce the viral load in that environment, the less the chances that you will pick the virus. And also the less the chances that the suspect or confirmed will reinfect themselves.
Okay. Just two questions from the chat. Meanwhile, those who want to ask, feel free to raise your hand. There is, just for clarity, sister, do you don on every patient in the ward being managed, or you don once until you see all the patients? Just for clarity.
You don once and go and do your work.
Okay.
You get it? And the big part of it, the worker is divided into according to how many you are.
Okay.
If we have different sessions,
Okay.
I may don't in to go and serve breakfast. Then I'm done, I come back. Another team go in and go for the old round. You get it? So the worker there doesn't, it's not that you're going to do everything at once. No, do your part, come back and give the report to the ingoing team.
Okay.
Yeah.
And there is another concern about the size of the PPE, that these PPEs usually fit a particular body mass. So are the oversized men and women supposed to use them because they can easily get torn?
So the ideal is all the sizes must be available. Yeah. We don't put on fittings in this scenario.
Okay.
Yeah.
And as a hospital a health worker, if you have noticed that PPE we are using, I have to echo this on the people who are on the call, is very expensive. Each of those PPE, if you're not careful, can be between $100 to $500 per piece.
Okay, how much is that to make it?
Depending. So that means it can move from 300,000 to almost 2 or 3 million.
One PPE.
Depending on its level. And what you have seen there is TIVET, one of the best that you can have.
Wow.
And that is what, as a country, we are using. So if you are to go into a treatment unit and you don't know your size, it means that you'll be putting on like five trials even before
you get the final.
So you're not really using your PPEs appropriately. So you need to know your size. If you're small, even before you open it, because the moment you open it, it is no longer what? Safe. So you should know your size. If you put on extra large, if you're not seeing it there, tell the donning master, my size is not there.
Okay.
And then the principle is that you can only go slightly a size above you, but you can never go a size below you. But of course, you're not going to do too many sizes above because it will be too hard for you to
overweight. And there is a concern. How do you note the patient details while you're dressed in this PPE and you want to jot down?
In a good system, we have whatever is in the treatment unit stays in the treatment what?
Okay.
So you can have a whole digital system in the what? In the treatment unit where you can type, take pictures if you have cameras and phones for inside.
Okay.
So these phones are not for putting on your ear, but they're for touch-free.
Touch-free.
You don't put on your ear, you just talk to it.
Okay.
And then in other advanced areas, we have what we call viewing boxes that are double distance where you can see from the other side, but we have moved to a digital whereby everything that is done is electronically transferred from the red zone to the green zone. In absence of that, we also use your memory. You know what you have done. If the patients are not too many, you take note of it, but nothing in the treatment unit leaves. Everything in the treatment unit stays there.
Maybe to add on what he's saying.
Okay.
You know, we're supposed to have two files.
Okay.
One in the green zone, one in red zone, but the information must match.
Yes.
So what you usually do, you can go and summarize your work in red zone if you don't have your phone. You summarize your information, for example, here. Come and stand on the door side. Somebody in the green zone takes a pic. Then you go and transfer this information to the file in the green zone.
Okay.
Yeah.
And two interesting questions. One of the doctors, Felician, says she's always been curious about auscultation during these ward rounds. Would you totally abandon that?
So if you have noticed, when I put on the coverall,
yes,
my ears are nowhere to be seen.
Yes.
And remember, I don't want the principle of not touching your soft pads comes in there. If I'm to auscultate, so in a treatment unit, we usually do non-invasive observations.
Okay.
So currently, as a country, we have really built the capacity to even go to the highest level of care in a treatment unit. Yes. So we have monitors that do the BPs. You use your hands to palpate if you really need to palpate, and that is if the patient remember what I said, and even in your hospitals, your biggest instrument before you even talk about PPE is risk assessment. The patient is obviously vomiting. Patient is obviously agitated.
Yeah.
Give the patient distance. If a patient is stable, then you can go closer and closer. But at any one point as you're doing your work, even in an isolation unit or in your hospital, the risk assessment. What is the level of risk if I don't do this procedure? Is there an alternative to auscultation? We have very many equipments that we have there. We have the ultrasound scans. I think some ETUs even have imaging inside the ETU.
Yeah.
So it is a total hospital there where you can get all the investigations, portable ultrasound, without necessarily putting yourself at risk as if it's a normal patient. So just know you're not touching the patient and you're minimizing the risk to yourself and to the entire team.
And that takes me to one exciting question now. This is really for me as an AM. Some of these patients in their advanced stages have organ failure and you may need to intubate them. So when it comes to endotracheal incubation, much as yes, you're done on this entire PPE, at one point with your laryngoscope, trust me, you will need to get closer to look for, that larynx. So are there any extra precautions for the invasive procedures, including ICU, critical care procedures?
Like I said, we are building and have built the capacity. The first thing is the safety of the health worker.
Correct.
If you have not yet, maybe doctor has not shared all the levels of PPE. We also have the self-respirating level 4 PPE. Okay. What we have shown you, yes, is level 4, but we also have levels that even go up above and beyond, whereby the doctor or the intensivist is fully in their own ecosystem as they are working. Okay. So as the team goes in, the intensivist and whoever is going to do that invasive procedure does the risk assessment and assesses what is my level of safety. If my level of safety is not guaranteed, we first prioritize the health worker before the patient. You do not do anything in the treatment unit or even an isolation unit and that's why I say we use a BADE system. So you may think you are safe, but me who is looking at you, I'm saying you're not safe.
And your gargle is
has gone
off.
So that's why you see you do not run a one-man show in there. The decisions are always team decisions. We do the assessment. If you're saying intubation, is there something which can be done without really intubating? Is there something, if we are to intubate, should we intubate this patient early before they become too hard to intubate?
Okay.
So you see, as a team, you make decisions. Should we use a certain drug to make this patient more calm during the intubation?
Okay.
So you do a lot of risk assessment and patient risk versus benefit of what you're doing.
Okay, I will take the questions now from the group. Rebecca Akelo, please ask your question.
Thank you so much, the great team. I'm so humbled and grateful for this knowledge. My question goes to sister who was demonstrating the procedure. You said you don't once and enter inside until you're done, then you come out. Now, supposing inside the room, yes, there is a green and then the red zone. If it's that same doctor who is going to assess those patients, in case of a ward round, are you going to use that same glove on all those patients, or you follow order depending on the rate of infection someone has? Thank you.
If you have noted, you have asked a very interesting question. I hope you understood what you are asking. By the moment you enter the moment I put on the PPE level 4, everything inside there is a red zone. There is nothing like green. But even in the patients, you classify the patient. We have suspects, we have confirmed, but a suspect can become confirmed. And also a confirmed patient can heal from the disease and they are now healing. You get what I mean? So those are the scenarios we have in there. We have patients that were confirmed and they are healing. And actually when you repeat their tests, they're actually now negative. So the principle of IPC as a health worker, even in the ETU, still suffices. But the difference is that instead of using maybe alcohol, maybe using soap and water on a normal ward, in a treatment unit, everything that we use for hand hygiene is 0.5% chlorine.
Okay.
We also have alcohol inside there for certain procedures on the patient, but when I'm moving from one patient on to the next patient, I perform hand hygiene, either with the alcohol, if I'm doing a less invasive procedure, or 0.5. Then the risk assessment, am I obviously soiled? And if I'm obviously soiled, you can see even the washing will not remove all the contaminants. It means that if I have worked on one patient and I'm obviously very soiled, I'm supposed to go and exit because I'm now a risk to the next one.
Next patient.
So I need to doff, then go. Another team can come and complete the work. Like sister said, work in the treatment unit never ends. So you cannot come, finish, but while compromising the infection prevention and control protocols inside there.
Okay.
Yeah, so even alcohol is used inside there, 0.5 is used, and the risk assessment on what I am doing is also done in there.
Maybe additionally, when you go into the treatment unit, we encourage the BADE system, somebody to look out for you, because sometimes you may not know that you're having a breach. Equally, when you get, for example, an incident, you have collapsed or you're feeling very weak, you get out as a pair. It's not about winning that I'm going to stay and be the resilient one. So usually when you're weak, when you're getting dizzy, when you're having anything, you tap your body and leave. You do not get out alone because you don't know, maybe by the time you're reaching outside, you cannot even help yourself. So we encourage the body system. And then also when somebody, for example, collapses and this is a fellow health worker, or even in any instance, it could be a patient, maybe you are triage and somebody collapses, we encourage staying calm. Many times we have seen panic gets people to breach IPC. The same applies to emergencies. Stay calm, find out what do you need, find out how do you ensure you're all safe. Because sometimes there are scenarios where we have had an emergency, a patient collapses and people breach IPC, they do not even have gloves. And before they know it, they're like, the whole team of health workers who worked on the patient have gotten infected. So stay calm, know your enemy. The enemy is the pathogen, it is Ebola. How is it spread? It is contact. How do you make sure you have all it takes to make sure you're preventing contact with body fluids, at the same time saving the patient? Sometimes you rush and the patient, yes, the life is very critical, but one patient can infect 100 health workers or 7 or 10. So you would rather selfishly lose one patient and save 10 health workers instead of rushing to save one patient who may die anyway and then also infecting all the other health workers. So that is very, very important. And then sessions like this may not really help everyone in the health unit. We encourage all of you to go back and retrain all your staff so that you don't wait to have a suspect and then you're like, hey, they said we need this PPE. But what do we need? That panic mode of you're moving all over the place is very, very dangerous. Thank you.
Okay, thank you, Dr. Nambuvilu. It's exactly 4 p.m., but I will request to borrow just 3 more minutes and we allow the last set of questions as I also ask our experts to prepare their parting shots. Anyone who has a burning question that has not been answered? Dr. Ntambi, there is a question that came through that do you self-isolate after doffing? And in the same regard, do health workers who work in the Ebola treatment units go home at the end of the day's work to their families, or they are also quarantined until the end of the outbreak?
There's something which I've asked. I think Dr. Sam also has a question there, but somebody asks, do I isolate after doffing?
Of course, now, if, for example, we've been in, all of us here, if we went for isolation, who will work tomorrow? As long as you practice your IPC as supposed to be done, there's no need of isolation. But I mean, for what? Unless if you have got signs and symptoms, there you can. Otherwise, we don't at all. You continue with your routine, you go and doff and don. We don't isolate, we don't hide. If I'm told, who will treat people now tomorrow?
So maybe to re-echo, remember what we talked about the register? You remember that I talked about a donim and doffing master?
Yeah.
So we are supposed to identify any event, and you know why we say by day system? Because the moment you have breached IPC, you are supposed to now be, because you have gotten in touch with the virus, because the virus is inside the what? The treatment unit. So it means the protocol which doctor took us through suffices. You are now treated as a contact, and that's why you go into the institutional quarantine. And then from there, if from a contact you become a suspect is one who has perhaps an epilink and has now symptoms. You're now also now treated as a suspect. Now a suspect now also is taken
inside
to the treatment unit in the suspect what? Until they get a result. If the result from a suspect is negative, you go back to being a contact until you finish the mandatory days of quarantine. If the suspect becomes a confirmed, you're now treated as a confirmed case, and you still go through the protocol, because even a confirmed case can become negative and still follows the protocol. So these are all protocols whereby if you are if maybe in isolation unit or you have a case, please make sure the surveillance team, you work with the teams and the categories for you what to do and follow the standard precautions, because those are the ones that will protect you. Okay. So we encourage that as a person who is working in the treatment unit, you try to limit your interactions with the other public, because you may even be safer in the treatment unit setting than in the outside setting in times of an outbreak.
Okay.
Yeah.
So the ETUs may be safer than outside. So members, Dr. Samuel, has your question been answered? I see your hand has been up. That will be the last question, and we close. Dr. Samuel? Okay, I think his hand is an old hand. So yes, the CPD points are there, and
hello.
Yes, doctor.
Yes, thank you so much, Tim. Mine was, of course, I appreciate the discussion much as it is more on the treatment center. But for us who are not even so much into the treatment center, ours is mainly isolation. But in the meantime, we are treating maybe dehydration, fever. We have a number of people going in there to look consultation for the patient as we await the confirmatory tests of the Ebola. But now my question is, we are also donning as we enter, because we are already defined the case as a suspect. And I have a nurse, I have a doctor, I have other people helping out with the patient as they are in isolation. Now, when it comes to these suits, down you have been telling us to don, is a bit expensive. I was wondering if the ministry has a way of helping us in the public sector to see that we have them subsidized or even free, so that we can treat our patients. Otherwise, if we use them, we are going to be charging them on the patients, and they are very expensive. Thank you.
Thank you so much. I think you actually meant the private sector. So
Yes.
currently what is happening is management of Ebola, whether it is private sector or government, it should be in conjunction with the Ministry of Health. So we do not envision private sector handling suspects alone, because like I said, you are not going to test those suspects on your own. So by the time you reach a level of putting on or requiring PPE, it means these are suspects in isolation, and these are not patients we encourage that you should manage alone as a private entity. So I still encourage you that get in touch with the Ministry of Health. We have the case management and IPC team. Get in touch, the patients will be assessed, and the ministry will get a way of supporting you either by transferring them to designated isolation or suspected treatment, Ebola treatment units, not for you to manage them in the private sector for now, because we really don't have those many cases. It is not yet at the level of we should have every hospital manage its suspects. So if there is an AP link and you feel this patient has signs and symptoms of Ebola, please notify us, and then we shall come and support you in whatever way that is required, including the PPE aspect.
Closing remarks for you.
And as I close, just like the previous speaker has said, it is very important that all of us are not in treatment units, but on record, most health worker infections occur during the routine care, because this is where we put our guard low and think we are not dealing with Ebola patients, yet Ebola patients can mimic any other disease. So let us practice infection prevention and control standards with or without a suspect. And today it is Ebola, tomorrow it could be chikungunya, the other day Marburg. You do not want to be counted among its numbers because these are very lethal cases. So let us always practice infection prevention and control, and don't wait. What can wait are the additional, the isolation and screening. But putting on gloves, washing hands is routine care that we should always do for all our patients. Thank you.
Thank you, Dr. Namubilu. Dr. Ntambi, any closing remarks?
Thank you for all the people that have attended. And first of all, I want to commend all of us health workers in the last 1 month that have been in this response, either in a private or a government setting. You are all heroes. IPC, like I keep on telling you, is to protect you, protect the environment, and protect the patient. I want to encourage all of us to embrace what knowledge is in those IPC guidelines. Let us go back and read as health workers. And every day we practice this IPC. It can save you. As you have noted, we had a number of cases, but not all health workers have gotten infection. It means that some people may have been able to perform the IPC, others may not have been able. Then finally, IPC is not only the gloves and what, but also the risk assessment. So always do a risk assessment at every point of care.
Okay.
When you come into a hospital, when you come into a ward, as you're doing a procedure, as you're exiting, do the risk assessment and find out what is the level of risk that I have exposed myself to. And please, if you have any person with symptoms of Ebola or anyone who has, it is better a patient is known to be positive than being thought to be negative and they are positive. There is nothing like over-reporting in an outbreak.
Okay. And I request Jimmy, you can type the number again for in case someone wants to report an Ebola suspect, the 800 number in the chat. I'm going to request all of us to be putting on our videos as Sister Comhendo also gives us her parting shots. We shall put on our videos so that we take a screenshot and say hello to each other. Yes, sister.
So thanks so much, members, for attending and sharing your time. I have 3 things I'm going to leave with you. 1 is IPC. Number 2 is IPC. Number 3 is IPC. Then you're good to go. Thank you.
Okay, members, I hope you've preached IPC, you've had IPC. So let us put on our videos, those listening in from the different parts of the world, of Kampala, of Uganda. Okay, please say hello to us. Just wave at us so that we see you. Okay, we can see people from all corners, including those on the world round. Some are not putting on a face mask. I can see them. They are seeing patients. And yes, thank you for coming. And yes, the number is 0800 100 066. In case you get a suspect, an Ebola suspect, the number once again is 0800 1066. Please let's all save it in our phones, in our notebooks. Let's share it to our WhatsApp groups. 0800 1066. And there is an option of sending an SMS. You write alert, you type quick details about the patient, maybe alert, Peter, ODM, 5-year-old, vomiting blood, and he's from Congo. No, and then you send to 6767. So with that, allow me to call this session to an end. It's exactly 13 minutes past our target time. Thank you all for logging in and have a lovely week.